All right, so we're doing pulmonary now, and or respiration, and these are my notes. So sarcoidosis. This is what it looks like, right there, there. Bilateral hilar adenopathy. It is a chronic granulomatous inflammation. Okay. Diagnostic strategy and suspected pulmonary embolism. So if you think someone has pulmonary embolism, this is how you go about it. Clinical assessment for PE, modified Wells criteria. If PE is likely, then you do CT of pulmonary angiography. If it's negative, then PE is excluded. If it is positive, then it is confirmed. However, if PE is unlikely, like they don't have the history for it, like they're not a smoker, they don't have um, stasis, unlike they weren't traveling or something. It seems like they shouldn't be having any of the PE symptoms, but they're having it. Then you do the D dimer assay. And if it's less than 500, then you can exclude it. But if it's more than 500, then you go about it with CT scan as well, angiography. Okay. So here the important part is CT, pulmonary angiography. The patient's tidal volume is 6 ml per kg. So you do 6 times whatever their weight is. Normal is around this. Aim for FiO2. FiO2 means inspired oxygen, the one that we give through the ventilation. It should be less than 60%. So if it's not less than 60%, if you're giving more than that, your goal is to get it down to 60% or lower. If not, then decrease to get it there before making any other adjustments with the mechanical ventilation. Okay. Selection of initial bronchodilator for stable COPD. Okay, so when it comes to COPD, this is different from asthma. Okay, even though they have like overlapping medication routines. For COPD, in selection of initial bronchodilator for stable or COPD. So you start over here. If they don't have exacerbation and the symptoms are pretty much on the lower end, you start with bronchodilators. For example, short-acting muscarinic antagonists as needed, right? So they only gotta take it when they need it. Um, then comes LABA and LAMA. That's long-acting beta 2 agonists, so that like formoterol, and long-acting muscarinic antagonist, right? LAMA. Um, so now it's not on as needed basis. This is like a daily occurrence, right? So uh, not requiring non-requiring hospitalization, and less than 2 requiring outpatient systemic corticosteroids. Okay. Okay. So again, you start off with bronchodilators as needed basis, PRN. After that, you go to daily LABA or LAMA. Then you go to, if there are higher exacerbation, if they have exacerbation on the higher end and anywhere they have the symptoms, then you do LAMA, and with ICS. All right. So this section is more than one requiring hospitalization or more than 2 requiring outpatient systemic corticosteroids. Okay. Compare that to step-up strategy for asthma treatment in adults. You start off with ICS, formoterol on as needed basis, PRN. Uh, right. This is less than daily. Okay. But now if they're having it like 3 times a week, then you go to step 3. Here you give inhaled corticosteroid plus formoterol daily. Formoterol is your long-acting beta agonist, B2 agonist. Um, Okay. Um, okay. So here you're gonna give low dose ICS. Okay. Uh, most days waking up with asthma. So that's where you give step 3. Then if that's not helping and they still find difficulty in breathing, this is where you go to step 4. Um, ICS, Fometrol daily. So now you're doing this on a daily basis, where ICS is going to be medium to high dose. So daily symptoms: waking up with asthma and decreased FEV1. Okay, and if that is still causing symptoms, then you go to step 5, uh, DEFCON 5, ICS plus Fometrol daily, high dose ICS, plus you're going to add LAMA here. Consider biologic therapy, anti-immunoglobulin E or anti-IL-5-IR MAB. Okay, still uncontrolled after step 4, then frequent need for OCS. OCS, oral corticosteroids. Okay, so here we're gonna add that, even if, okay, cool. Reliever is ICS and Fometrol as needed basis. Adjunctive controller therapies, LTRA, that is leukotriene receptor antagonists, allergy immunotherapy. All right, so on to acute bronchitis. Okay, so before we start that, let's read about it. So, dry cough more than 5 days can be considered acute bronchitis. If they have scattered wheezing, history of asthma, give bronchodilators, um, and do chest x ray on patients suspected of pneumonia or elderly patients, and patients with COPD where pneumonia is subtle. So, acute bronchitis etiology is preceding respiratory illness, so they usually have an illness. Um, like viral sore throat and all that stuff, and then they didn't stop coughing. It's called acute bronchitis. Clinical presentation: cough for more than 5 days to 3 weeks, up to 3 weeks, right? With or without purulent sputum, absent since systemic findings. Okay, so they don't have fever and chills. Wheezing or rhonchi. This is after 5 days, right? Wheezing or rhonchi, chest wall tenderness. Diagnosis and treatment is clinical diagnosis, chest x-ray only when pneumonia suspected. Uh, Symptomatic treatment, NSAIDs and or bronchodilators. Antibiotics are not recommended. Okay. Patient with a history of chronic cough, 4 months, that is worse at night. Chest x-ray is normal and auscultation is normal. Now this has been 4 months. So patient is already on omeprazole for GERD and over-the-counter diphenhydramine. So next best step is pulmonary function test. Do PFT, as nocturnal cough may be a sign of asthma. Okay, so here nocturnal cough is important. Okay, obstructive sleep apnea. History will be of choking and sleep. It is due to intermittent collapse of airways. Here we have a history of young female patient troubled breathing during exercise. And you can hear an inspiratory stridor. Uh, Episodes can occur due to strong smell, exercise, or stress. Diagnosis here is laryngoscopy. Why? Because they have paradoxical vocal cord motion. So that's what that is. Here you have a history of someone having trouble breathing during exercise. It can also occur due to strong smells or stress. So diagnosis here is going to be laryngoscopy. Treatment is education and speech therapy. Sniffing and panting during episode may occur as well. Okay. So history of COPD plus neurocomplex tachy with varying, and even Google don't know what I meant there. varying amount P-wave and PR complexes. Treatment here is monitor while treating COPD exacerbation. Okay. Excuse me. Uh, right. So treatment here is monitor while treating COPD exacerbation. That's what this is. Multifocal arterial atrial tachycardia. Etiology is exacerbation of pulmonary disease, for example, COPD. Okay. Electrolyte disturbances like hypokalemia and catecholamine surges like sepsis. Clinical findings going to be typically asymptomatic. However, there may be rapid or irregular pulses, and ECG will show more than 3 P waveforms and atrial rate more than 100 per minute. Treatment is correct underlying disturbance, AV nodal blockade, for example, verapamil if persistent. Right? So fix the hypokalemia or treat COPD, so correct underlying disturbances. Alpha 1 antitrypsin. Here you will have family history plus COPD symptoms in less than 45-year-olds. Lab will show slight increase in LFT. History is going to be hyperlucency seen at base plus no V's heard on auscultation. Okay, so hyperlucency is going to be seen. You'll see no V's heard. Okay, so you'll hear no V's on auscultation. Okay. By family history, it just means there was a history of lung and liver problems. All right. SIAD, inappropriate secretion of ADH. History is going to be euvolemic hyponatremia. Okay. Low serum albumin. Okay. And chronic cough more than usual smoker cough. So the person is going to be smoker and they'll come and they'll be like, "Hey doc, I've been coughing more than usual, um, and like more than usual of smoker cough," and that's what the history will be about. Um, this is due to small cell cancer. Treatment here is going to be initially fluid restriction. So let's get that under control for asymptomatic patient or mildly symptomatic patients. Okay. Dyspnea is normal in pregnancy at 33 weeks. Okay, so pulmonary changes in pregnancy. To recap, pathophysiology, progesterone-induced hyperventilation. Clinical features are dyspnea of pregnancy, uh, increase in partial pressure of oxygen, and decrease in partial pressure of carbon dioxide. Respiratory alkalosis, lung volumes, there will be increase in minute ventilation, mostly via increase in tidal volume, decrease in residual volume, and functional residual capacity. And there will be normal vital capacity and FEV1. So here, this one we already knew from step one, increase in minute ventilation, right? Decrease in residual volume and functional residual capacity. Okay, because we need all the spaces that are not being used now because the lady is going to be breathing for both her and the fetus. Okay, try to make it sense. Normal vital capacity and FEV1. Since the respiration is up, the volume doesn't need to be up. Okay. Uh, Fatal asthma risk factors. There's a history of non-invasive positive pressure ventilation and intubation. So now you're gonna go with ICU admission. Okay. Fatal asthma risk factors. So these are the risk factors that they have already been put on ventilation. They have been intubated. Next thing is ICU admission. Okay. So acute chest syndrome in patients with sickle cell disease, plus chest x-ray infiltrate seen. Okay, so that thing right there. Right middle lobe infiltrate, right medial lobe, middle lobe opacity. Okay, so this is called acute chest syndrome. It is seen in sickle cell disease. Treatment here is antibiotics, Cef or Azithro, um, because acute chest syndrome is indistinguishable from pneumonia, so you gotta cover your bases. Okay. Um, Pathogenesis is going to be vaso-occlusion of pulmonary vasculature. That is important. That's what acute chest syndrome is. Vaso-occlusion of pulmonary vasculature, most commonly triggered by fat embolus, usually adults, or infection, usually in children. Uh, Diagnostic criteria here is new pulmonary infiltrate on chest x-ray plus more than one or equal to one of the following: increased work of breathing, cough, tachypnea, or wheezing. Temperature is more than 38.5 degrees Celsius or 101.3. Hypoxemia and chest pain. Initial treatment is ceftriaxone and azithromycin. Uh, so that's beta-lactam and macrolide. Intravenous fluid and pain control. Okay. Uh, Lung granuloma finding on chest x-ray and biopsy. Coccidiomycosis. Unilateral lung infiltrate is seen with ipsilateral lymphadenopathy, and it shows endospores. Histoplasma, that will be bilateral lung infiltrate and hilar lymphadenopathy, and it shows yeast. Okay. Now, say you have hilar lymphadenopathy plus tuberculosis like symptoms plus adrenal insufficiency. So that is hyponatremia and hyperkalemia. Um, so that is aldosterone deficiency, right? Because aldosterone reabsorbs sodium and excretes potassium. Okay, so now here we have the opposite. Plus peripheral eosinophils. This is an odd finding, but that's going to help you to figure out that it is miliary tuberculosis. It is seen in Addison's. It leads to Addison's primary adrenal insufficiency. Okay. Water break. Okay. Again, history. Hodgkin's lymphoma. They had Hodgkin's lymphoma, and now it's cured. And over 20 years, it's been over 20 years. A new chest X-ray finding that looks like a ball. Okay. Remember when we did Hodgkin's and hemat? They said that in a person who has cured Hodgkin's lymphoma, they'll have an increased risk of other malignancies or something during the lifetime, right? So that's what this is. So left lung mass. Chances are that's going to be a malignancy. So with cured HL, risk increases for secondary malignancy in lifetime. Lung cancer is the most likely cause of the chest X-ray finding. Okay. Um, Evaluation of subacute 3 to 8 weeks of. Okay, actually, let's go with this first. With cough seen in non-smokers, it's usually due to. Oh, okay, so we're talking about subacute or chronic cough. Okay, subacute is 3 to 8 weeks. Chronic is more than 8 weeks or 2 months. Okay. With cough seen in non-smokers, it's usually due to GERD or asthma. More than 90% of chronic cough. Okay. Common etiologies of chronic cough: upper airway disorders, upper airway cough syndrome, postnasal drip, and chronic sinusitis. Lower airway and parenchymal disorder, asthma, post respiratory tract infection, chronic bronchitis, bronchiectasis, lung cancer, non asthmatic eosinophilic bronchitis, and other causes are GERD and ACE inhibitor. So, this patient's cough started after a recent upper respiratory infection, and it occurs primarily at night and is without expectoration, right? So, cough following upper respiratory infection, which can be due to upper airway, uh, UACS is upper airway cough syndrome, or effects of the virus. The best approach is to treat empirically with an oral first generation antihistamine, for example, chlorpheniramine, or combined antihistamine decongestants, for example, brompheniramine or pseudoephedrine. Despite their sedating effects, first generation antihistamines are used because they are more effective. This approach differs from that used for symptoms thought to be due to rhinitis, in which intranasal glucocorticoids are first line. Patients who do not respond after 2 to 3 weeks may require further investigation, for example, sinus imaging or pulmonary function test or HRCT scan of the chest or empiric sequential therapy for GERD, cough variant asthma, chronic sinusitis, and non asthmatic eosinophilic bronchitis. Okay, so we do all of that. Here's the algorithm for it. So you have suspected etiology on HNP. So you evaluate HNP as history and physical. So then you go to evaluate and treat as indicated. So first, if they have ACE inhibitor history, then you stop ACE. If they have upper airway cough syndrome, then you do first generation H1 blockers. Asthma, then you do pulmonary function test. If they have GERD, then you do empiric PPI. If there is no improvement even after these interventions, then you do chest x-ray. On the other hand, uh, if they have a history of parenchymal disease or purulent sputum, and if they're immunocompromised, or there's no specific etiology, you go straight to chest x-ray. Okay. In acute respiratory distress syndrome, there is avoid having positive fluid balance. Okay, that is important to do. Um, this is the sum of all fluid intake. So dry lungs is happy lungs in ARDS. Okay, so you're gonna have to avoid having positive fluid balance. So this note was about what this means. Positive fluid balance. It means you want to keep it in the negatives. Okay, so this is the sum of all fluid intake. Remember, dry lungs equals happy lungs. So what is this? It's just a scan of that scattered ground glass opacities caused by interstitial inflammation. This is pneumocystis jirovecii pneumonia. Uh, and here you have PE associated infract and pleural effusion. You see a wedge shaped right there, and this is pleural effusion right here. Okay, that's what that looks like. And then you have community acquired pneumonia right here, like a little cotton blur. Right upper lobe consolidation. This is community acquired pneumonia. Okay, so exercise induced bronchoconstriction management is you're gonna do inhale corticosteroid plus long acting beta agonist 10 minutes prior to exercise. Okay, so if someone comes in with a complaint of that they're breathing okay until they reach the gym, and as soon as they start warming up or they start doing their exercises, that's when they start having difficulty in breathing. This is how we manage it. 10 minutes prior the exercise. It's not a daily thing. Um, okay. I don't think we need to go into details, so I'm just going to go to management, improve control of underlying asthma, that is step up therapy, pre-medicate before exercise, ICS, formoterol 10 minutes prior, preferred over SABA or LTRA, that is leukotriene receptor antagonist and short-acting beta agonist. Okay. Daily ICS, beta agonist, or LTRA may be needed for frequent prolonged exercises. So if they're like training for something coming up, then you might as well give them a daily thing. Okay, so if you're giving SABA and LTRA, that is 2 hours prior, and that's usually hard to remember because whenever you want to go to the gym, it's usually like, okay, spontaneous thing. I feel like going, or it's already planned, and you're good with that. Then maybe this would work. I don't know, but still, I think they prefer this because it shows a better outcome. Okay. And oh, they give you exercise. Um, Appears within 5 to 10 minutes and improves after 20 minutes. Yeah, that's important. It improves after 20 minutes of rest or of exercise. Okay. Anyways, moving on. Management of stable chronic obstructive pulmonary disease, COPD. Okay, stable COPD. So how do you manage it? If it's less than 89 SpO2, with increased hematocrit, then you need supplement it with O2 oxygen. If SpO2 is above 92%, then pulmonary rehabilitation is required. Okay, so what are the non-pharmacologic management you need to ask them to do? Smoking cessation, pulmonary rehabilitation, vaccination, influenza, pneumococcal COVID-19, long-term oxygen therapy if saturated oxygen is less than 88% at rest, nocturnal non-invasive ventilation if daytime hypercapnia. The most important one out of all of this is which one? Smoking cessation. Okay, that's the most important one. It actually reduces mortality if they are going to stop smoking. So that's the first thing you ask them to do. Okay, and surgical, uh, lung volume reduction or lung transplantation for advanced disease, medication, bronchodilators, lama-laba with or without ICS, long-term macrolides, azithromycin 3 times weekly, PDE4 inhibitors, for example, rumiflumast, reduces hospitalization for patients with frequent exacerbations. Okay, both of these. Biologic therapy, for example, anti-interleukin 5, MAB, if eosinophilic or asthma overlap. Okay. So here, smoking cessation reduces mortality. Okay. All of these show to, yeah, all of these reduce mortality. Okay. Okay, so there causes diffuse alveolar hemorrhage. Smoke crack. कोकेन कि तू मैनू चढ़े आवे जोश. It's actually from Bohemia. Okay, so if they smoke crack, it causes diffuse alveolar hemorrhage. Water break. Okay, so smokes crack, it causes diffuse alveolar hemorrhage. And next, chronic dyspnea and sickle cell disease. We sort of went over the acute one for this. Sickle cell, it causes pulmonary hypertension, intravascular hemolysis. which leads to pulmonary vascular remodeling. Symptoms include exertional dyspnea and signs of right sided heart failure. Um, so you'll see hepatomegaly or edema. Chronic dyspnea in sickle cell disease causes are asthma, pulmonary hypertension, and pulmonary fibrosis. And asthma symptoms are, you know what they are. Diagnostic pulmonary function testing shows reversible airway obstruction. Pulmonary hypertension, exertion dyspnea, signs of right heart, sided heart failure. For example, jugular distension, edema. Diagnostic findings are going to be here for tricuspid regurgitation on echocardiograph, uh, graphy, increase in pulmonary arterial pressure on the right-sided heart catheterization. Okay, pulmonary fibrosis, exertional dyspnea, and progressive uh, dyspnea. Okay. Diagnostic finding for fibrosis, honeycomb pattern on chest CT scan. Pulmonary function testing shows restrictive pattern. Okay. Uh, so there's decrease respi rate to improve. Oh, okay. During assisted ventilation, patient is on appropriate tidal volume and 18 respiratory rate. Okay, so assisted ventilation, patient is on appropriate tidal volume and there's 18 respiratory rate, but has developed respi alkalosis, so that is decrease in PaCO2 uh, or hypocapnia, right? So what will you do here? Probably decrease this would be smarter. Decrease respiratory rate to improve the alkalosis, yes. Increasing tidal volume will increase the ventilation and lead to worsening of the alkalosis. So that's why we don't do that. Okay. Positive pressure ventilation. Complication here is pneumothorax, alveolar damage, and hypotension. Hypotension is not seen in atelectasis. So, um, okay. So when you're trying to figure out if it's pneumothorax or atelectasis, you don't get hypotension in atelectasis, but you will get hypotension in pneumothorax. Okay. So positive pressure ventilation complication is that there will be air, because it bursted out the alveoli and it's leaking air there. Alveolar damage and hypertension. Hypertension is not seen in atelectasis. Pneumothorax sign and symptoms. For pneumothorax is shortness of breath, hypertension, tachycardia, tracheal deviation, and unilateral absence of breath sounds. Okay, so whichever side it's uh, weakened or leaking air, that you will have absent air sounds there. Hypercapnia due to drug OD. Okay, so uh, they overdosed and now they have hypercapnia because there's buildup of carbon dioxide in the body when because of respi depression. So when on ventilation and confirmed by seeing respi acidosis to correct it, increase RR, respiratory rate, or tidal volume. Okay, so when you have hypercapnia and they're on mechanical ventilation and you see that there is respi acidosis because of buildup of carbon dioxide, to correct it, increase the respiratory rate or tidal volume. Okay, either or. Minute volume, minute ventilation is equal to respiratory rate times tidal volume. So you could either increase this to increase minute ventilation, or you can increase this to increase ventilation. Increasing the RR is preferred because tidal volume more than 6 to 8 milliliter per kilogram will increase the risk of pulmonary barotrauma, and then you can get pneumothorax due to that. So we prefer just increasing respiratory rate if we have tidal volume in this range already. New onset of asthma, what do? You give albuterol. Inhaled short-acting beta agonist, or SABA. Um, okay, it's for bronchodilation and okay, so albuterol for bronchodilation and prednisone, glucocorticoid to reduce airway inflammation. So we give albuterol and prednisone in new onset asthma. Okay. Okay. So if you have seen the video on recipe chapter from step 2 FA, we go over this over there. Um, right, so that's where this is from, and this is from the QBank. Okay. If there is an increase in inspiratory pressure apply means there is increase in resistance. Okay, so let's go through this. Just quick recap. So this is inspiration, hold, and then expiration. That's what this is showing. Okay, so now if this is baseline and um, okay, so there's a peak and a plat, pathophysiology and causes of management. I'm just trying to remember what it was. Okay, so if there is an increase in peak, but the baseline plateau pressure is the same as before you applied uh, the intubation and all that stuff, and then you checked it out, then what's actually happening is there is an increase in airway resistance. Okay, the way I remember is just I remember this chart. So if the peak is the only thing that's increasing, then there is increased resistance, right? Because you had to overcome what this is inspiration, right? So if you're increasing the pressure of inspiration, that means something is stuck within the pipe and it's causing you to apply more pressure, and that's what that means. So that's why it's increased airway resistance but normal lung compliance. Since this is right there, that has not increased. um, that means the lungs can do what it does already at its optimum level, because this is the optimum level. So what could cause these things where you would have to increase the pressure of inspiration? Think airway. So kinked endotracheal tube or untangle mucus plug. If it's tube untangle, it could be mucus plug, suction mucus in that case. It could be bronchospasm, then you give bronchodilator, and or it could be that there's a narrow endotracheal tube. Okay, so that was for increased resistance. Now, how do you check if it's decreased compliance? So you're gonna ask them to breathe in all the way. So it's gonna be increased. There will be increase in peak and increase in plat in this case. So that is the plateau, baseline plateau, and that has increased as well, right? So now the thing that's causing this is because of the thing that's causing this, and there is a decreased compliance. So you have to overcome that. Um, that's why you're applying the pressure during inspiration. Okay, so there's increase in PIP. This was the baseline, and this is increase in plateau resistive pressure here. Maintains the difference though. So this is going to be the same as this black line is the same as the black line from here to here. Okay. Pathophysiology is that there is a normal airway resistance but reduced lung compliance. So causes and management for decreased compliance, think lung. Um, Main stem intubation. Um, Here you retract the tube. Atelectasis, you would in that case do chest percussion and bronchoscopy. Um, if there's pulmonary, it could be pulmonary edema. Here you do diuretics, ARDS. Uh, you manage it with low tidal volume or high PEP. Okay. Um, Ventilation strategy, and this is an important one because this gets tested on individually as well. ARDS, you do low tidal volume uh, to prevent uh, prevent the overexpansion of the alveoli. High PEEP ventilation strategy. Okay. Pneumothorax. In that case, you do a chest tube, and it could be because of pneumonia. Okay. So we'll come back to this after this. Okay. So now that you know something about that, let's read this. If there is increase in inspiratory pressure, you apply. Uh, it means there is increase in resistance. So increase in peak inspiratory pressure, increase in resistance is equal to increase in resistance. It could be due to mucus plugging or bronchospasms or any of these things right here. Okay. Pressure needed to expand the lungs and elastic pressure is elastic pressure. Okay, so pressure needed to expand the lungs is elastic pressure. When this pressure increases, then the respiratory system compliance decreases, seen in pulmonary edema or abdo compartment syndrome. Okay, or any of these. So these two make up total pressure, which is equal to the resistive plus the elastic pressure. To differentiate between the two pressures, we can hold the ventilation at the end of full tidal volume deliverance. Okay, and that's what they mean. After you've done the maximum respiration, you ask them to hold the, well, you don't ask, you hold the pressure through your ventilation machine. Okay, so you can hold the ventilation at the end of full tidal volume deliverance. This is known as the inspiratory hold maneuver. uh, Resistive component is 0 here, right? Because you have already overcome the resistance that is required to get the air into the lungs. Okay, this will give you the plateau pressure, which reflects the elastic pressure. So after it's done and the hold, that is where the plateau is. Okay, if there's no hold, it would go down like that. So if there's hold, it's over there. Okay, so this is known as the inspiratory hold. Resistive component is 0. This will give the plateau pressure, which reflects the elastic pressure. So why do this? Why we do this maneuver to localize the problem when mechanical ventilation becomes difficult. Okay. So the results are, if there is plateau, if plateau is normal, then increased airway resistance. So bronchospasm is the cause, or any of these that we discussed up here. And if plateau is elevated, so this is an elevated plateau right here, and this is just a PAP and normal plateau, right? So normal plateau, increased airway, bronchospasm. So um, increase in airway resistance, biting the endotracheal tube, bronchospasm, or mucus plugging. And plateau is equal to elevated, decreased respiratory system compliance, pulmonary edema. Plateau, okay, so if it's increased, there's decreased respiratory system compliance, pulmonary edema, pneumothorax, abdominal compartment syndrome. Okay, so now we are expert in that. Okay, so just to recap, if plateau is normal, it's increased resistance. If everything is increased, then it's decreased compliance. Mechanical ventilation, when is the patient ready to be extubated? Okay, so a patient is on mechanical ventilation, everything is coming up correct for him. Like all the vitals are normal now, lab values are getting normal. So when do you decide uh, to extubate the patient? We want to take it out as soon as possible, obviously, to avoid complication like pneumonia or barotrauma. Extubation readiness criteria is this. The pH has to be more than 7.25. Um, Adequate oxygenation. For example, FiO2 is more than 60 mmHg, 60%. I mean, under 60, sorry. PO2, partial pressure of oxygen, needs to be 60 mmHg or more on minimal support. That is, FiO2 has to be less than 40%. Okay. and PEP needs to be less than or equal to 5 centimeters H2O. Intact inspiratory effort and sufficient mental alertness to protect the airway is required as well. Okay, so pH 7.25 or more, uh, 7.26 or more. Um, Organization. Oops, okay, there it is. Oxygenation. Sorry, oxygenation more than 60 mmHg. FiO2 less than 40%. PEP less than or equal to 5, and intact inspiratory effort and sufficient mental alertness. Got it. Once these criteria are met, we do spontaneous breathing trial to help confirm readiness for extubation. Okay, so what is spontaneous breathing trial? It's you keep them intubation. You keep them intubated. Then ventilation is turned off for a short time, that is 1 to 2 hours. If the patient maintains normal ABG, arterial blood gas, throughout the spontaneous breathing trial, they are good candidates for successful extubation. In addition, when doing SBT, we can further assess candidacy for extubation via rapid shallow breathing index. This is not required for you to know. I don't think it was tested on. It was just one of the notes in the QBank. So I added it here because I didn't know about it. In addition, when doing SBT, we can further assess candidacy for extubation via rapid shallow breathing index, RSBI. This is respiratory rate divided by tidal volume. Okay. Patients with high RSBI, that is more than 105, are breathing fast and shallow, and are unlikely to do well without continued ventilatory support. Okay, and that's how we decide to extubate. These three are the important points right here, so remember those. Acute exacerbation of COPD patient. Already on medications, still no improvement, right? So if there's acute exacerbation of COPD, who they were already on medication, but they didn't see any improvement, they came to emergency department. Next best step, what is it? You start in non-invasive positive pressure ventilation. If no improvement in 2 hours, then you intubate and mechanically ventilate the patient. Okay. Asbestos. History here: smoker. It could be a smoker and a plumber patient who works as a plumber. CT scan will show reticular opacities of the lower lung fields, multiple pleural plaques, and around 6 centimeter cavitary mass in the right lower lung field. You will see clubbing, and finding on biopsy will be bronchogenic carcinoma. Okay. Side note here is peritoneal mesothelioma is a rare disease linked to asbestos exposure. Patients typically develop abdominal pain and distension due to possible ascites, early CTAD, nausea, and weight loss. Okay, so abdominal pain, distension, early CTAD, nausea, and weight loss. CT typically shows nodular peritoneal thickening with moderate to severe ascites. COPD patient plus smoker plus knee surgery scheduled. Okay, so they're a COPD patient, they're a smoker, and there's a knee surgery schedule. How to reduce post-op pulmonary complication? Stop smoking, my guy. Those that quit smoking more than 4 to 8 weeks prior to surgery substantially decrease their post-operative pulmonary risk. Okay. All right. Water break. Um, Pulmonary findings, and we're talking about condition, breath sounds, tactile fremitus, percussion, and mediastinal shift. You already did this in step one, so I'll just quickly go over it. Normal lung. Breath sounds are bronchiovascular, hilar, in the hilar area, and vascular and peripheral sides. Tactile fremitus, normal, and percussion is resonance, and mediastinal shift is none. Uh, During consolidation, this is the only one that has increased breath sound and increased tactile fremitus. None of the other ones will have increased tactile fremitus or breath sounds. Percussion is dull, and there's no mediastinal shift either. Okay, and pleural effusion. Um, Mostly all of these have decrease in breath sound and tactile fremitus, and this is where others differ. Percussion is dull, and mediastinal shift will be away from effusion. Okay, because basically like a mass effect of fluid that's pushing it away if it's large. Pneumothorax is decreased or absent. Tactile fremitus is going to be decreased. Percussion here is going to be hyper resonance. If you have hyper resonance, it's pneumothorax. And again, mediastinal shift is away from tension pneumothorax. And atelectasis, for example, mucus plugging, breath sounds are decreased or absent. Tactile fremitus is decreased. Percussion is dull, and here it's going to be towards the atelectasis mediastinal shift. Okay, we have 56-year-old smoker for over 20 years and 0.5 centimeter hyperplastic polyp seen during colonoscopy, and age 52. Okay, so smoker, 20 years, over 0.5 centimeter hyperplastic polyp seen during colonoscopy, and 52. So here, next best step, what is it, right? Since this is hyperplastic polyp, it is not malignant, and it is small. Okay, so we don't need to worry about that. But this is a 56-year-old and a smoker, and has been for over 20 years. We do low dose CT scan, not colonoscopy, as we worry about adenomatous polyps, cancerous ones. Other than that, screening is recommended every 10 years. So we are going to screen him for lung stuff. Okay. Septic shock. Early septic shock leads to an increase in stroke volume. Okay, so if there's a patient with septic shock confirmed, um, what are the other things that we gotta worry about? So early septic shock leads to an increase in stroke volume, heart rate, and pulse pressure, which results in bounding peripheral pulse. So this is probably what was important. You get bounding peripheral pulses. Kind of this reminds you of water hammer pulse. So you get the same thing in septic shock. Okay. Why? Because this thing dilates the arteries, if I remember correctly, right? Okay. And since your heart rate is increased, it's pushing a lot of blood, but since it's vasodilated, you get bounding peripheral pulses. Okay. Asthma, patient with asthma, diabetes mellitus, hypertension, lisinopril, they're taking lisinopril, plus nighttime cough and wheezing. They gained 5 kilogram weight recently and no change in medications. You would think it's due to the ACE inhibitor. Wait, ACE inhibitor? Yes. Pro. So something like bradykinin stuff happening, but you give GERD, it could be GERD, and give PPI esomeprazole. Why? Because this is nighttime only when they're laying down, and they have gained 5 kilogram weight recently, right? Because they have been eating a lot. So since there's no change in medication in the recent times, it's probably not because of lisinopril. Okay. So you're gonna treat them for GERD. So you give PPI, esomeprazole. ALS, just know it. um, yeah, I don't know. I think I missed a note there, but anyways. Occupational asthma. So first confirm asthma, then confirm the workplace asthma. Okay. So how do you diagnose it? You do by doing peak expiratory flow measurement at home and work using a portable peak meter. Okay, so this is what it looks like. Uh, Peak expiratory flow uh, rate. Okay, decline for more than 20% at work, more than home is consistent with occupational asthma. Okay, so what is occupational asthma? You get a rough idea of this, but we'll go through this. Pathogenesis and high risk occupations, workplace antigen, more than inflammation, immunoglobulin E dependent or independent, more than bronchoconstriction, classic antigens, animal proteins, for example, animal workers, seafood processors, grain hydrates, for example, bakers, isocyanates, for example, painters or metal workers like welders. Latency is seen months or years due to gradual sensitization. Okay. Clinical features, initially symptoms clearly exacerbated at workplace and relieved at home. Over time, it could be that they went away at someplace else to on vacation, and all their symptoms went away. But as soon as they came back and started working, it came back. Over time, symptoms persist throughout week and subside only after sustained work absence. Diagnosis, confirm asthma or PHR, for example, methacholine, bronchoprovocation, uh, that leads to confirm workplace specific worsening of obstruction. For example, serial PEFR at home and work. Management here is antigen avoidance, change of workplace if possible, or reduction. For example, respirator or shift rotation. Bronchodilators, and inhaled corticosteroids. Okay, bronchodilators or inhaled corticosteroids. That's the normal way to go about asthma, anyways. Desensitization, immunotherapy. Okay, the patient had breakfast an hour ago and now it has shortness of breath, breathing difficulties due to laryngeal edema. Okay, uh, due to anaphylaxis. Differentiating between the two is tough if you don't remember the points here. Okay, so characteristic of high altitude pulmonary edema versus multifocal pneumonia. So if you had to differentiate between high altitude pulmonary edema or multifocal pneumonia, this is what you need to remember for that. So high altitude pulmonary edema, history of skiing or high altitude like mountaineering or something. uh, Leukocytosis will be less than, however, okay, so there will be leukocytosis, but it will be lower than 50,000, 15,000. Procalcitonin is going to be normal. This is a biomarker for bacterial infection. Okay, procalcitonin is normal. So since there's no bacterial infection, right? Like in multifocal pneumonia. O2 improves condition in less than 6 hours. So if you put them on O2, condition is improved already in 6 hours. Okay. So again, we'll recap that here and then look for pneumonias. So HAPE, recent arrival at high altitude, less than 1 week, absent or mild leukocytosis. Procalcitonin is normal, marked early improvement with oxygen. Whereas in multifocal pneumonia, you'll have persistent stay at high altitude. Leukocytosis is more than 15,000 with bands. Procalcitonin is elevated, minimal early improvement with O2. Okay. For metabolic acidosis questions, okay, let's take a break here and then we'll continue with this. All right. Um, so for metabolic acidosis questions, how do we approach them? Always check the anion gap first. That is the sodium level minus the summation of chloride plus bicarb, right? So if it is you get anion gap of normal, then it's just metabolic acidosis. If you get a anion gap that is increased, normal is between 10 to 14. Um, this is different than what you have seen in step 1 book. So remember this value now, 10 to 14. Then your next step is to do the Winter's formula. Uh, I remember this being intimidating when I did it in step 1, but it makes a lot more sense now why we do this, because I've seen a lot more questions about it. So you do Winter's formula to calculate predicted PCO2. If actual PCO2 does not fall in the range of predicted PCO2, it is improper compensation. That means it is respiratory acidosis or respiratory alkalosis, as well as metabolic acidosis. Okay, so here the predicted one is the one that we calculate via Winter's formula, and the actual one is the one that is shown in the lab work. Okay, so if improper compensation, then something else is going on as well. Okay, um I thought that would be here, but the Winter's formula is 1.5 times the bicarb levels is 3 plus 8, and then plus minus 2. So this is the range. So say bicarb is I mean this up to here, up to 8, it is like, I don't know, how much should it be, like 30 for instance, right? So it could be if the lab value lands anywhere from 28 to 32, then it's properly compensated. But if it gets either lower or higher, then it's incompensated, right? Improperly compensated. Okay, so you need to know this formula: 1.5 times 8 CO3 plus 8. Okay, and plus minus 2. If the lab PCO2 is less than the range that we came up with right here, then it is respiratory alkalosis along with metabolic acidosis, right? It could happen because of hyperventilation or psychiatric uh, drugs, um, fever, or high altitude. If the lab PCO2, actual PCO2, is more than the range that we predicted right here, it is respiratory acidosis along with metabolic acidosis. So here you have hypoventilation. Okay, it could be because of hypoventilation or fatigue, neuromuscular problems, or COPD. Interestingly, neuromuscular problem, the ALS thing right here, it can apply here as well. Okay, or it could be that they had an acute exacerbation of COPD, right? And they have been using their respiratory accessory muscles and everything to breathe. But eventually, what's going to happen is, if you have done this yourself, if you breathe too hard for too long, you start getting tired, right? So that comes under this as well. That the diaphragm is now not able to hyperventilate, um, keep up with the hyperventilation, and eventually it's going to get tired out, and that is a muscular problem, neuromuscular problem as well. Okay. So hyperventilation. Initial treatment is reassurance. Okay, so if say a person has panic attack or something and they're hyperventilating, so how do you treat it? Initial treatment is reassurance with breathing retraining. Uh, this is important. This is abdominal diaphragmatic breathing. That's what it's called. Previously, breathing into a paper bag was recommended to improve hypocarbia by rebreathing CO2. Um, However, this can only result in hypoxia and therefore should not be done. Okay. So this is important as well. Here that it means breathing retraining is that you breathe from the abdomen while keeping the chest still. Okay, so abdomen diaphragmatic breathing while keeping the chest still. That's how you tell them to breathe. Um, and you don't ask them to breathe into a paper bag because that can worsen the hypoxia. I mean, it can result in hypoxia. Okay. Usually viral, acute bronchitis. Okay, so acute bronchitis, it's usually viral. Okay. This is when the cough is more than 5 days to 3 up to 3 weeks. Um, you get purulent sputum, or it could be blood-stained sputum as well. But there are absent systemic findings like fever or chills between this. Wheezing or rhonchi, chest wall tenderness is present. Okay. So how do you diagnose and treat it? Clinical diagnosis is only chest X-ray only done when pneumonia is suspected. Okay. But if you don't suspect any pneumonia, like there's no crackle, there's no unilateral rhonchi or something like that. I don't know. Um, Not rhonchi, but crackle. I think is that, and maybe wheezing, I guess. Then you might want to go with this. Also, if the patient themselves are living in like a facility, assisted facility, or they're older, then maybe you want to go with this. But if they're young and you know that nothing else is there, then go with. Okay, so wheezing is for this. Okay, so not pneumonia. Anyways, you get the idea. Okay. Give symptomatic treatment. NSAIDs and bronchodilators. Antibiotics are not recommended, so don't do that. Okay. In acute bronchitis, more than 5 up to 3 weeks. So Curb 65. This is an important mnemonic for um when you're managing community acquired pneumonia. So you need to know if it is community acquired pneumonia or not. This is how you figure it out. Okay. Um, C is for confusion. If they're confused, U is for urea is more than 20 mg per deciliter. Respiration, R, is more than 30 or equal to 30 per minute. B is for blood pressure, where the systolic is less than 90 or diastolic is less than 60. Okay. And age is more than 65. 65 or more. Okay. If you get so each of these is 1 point. If you get 0 to 1 point, then it's a low mortality, 0.7 to 3% only. You treat it outpatient treatment. Okay. um if you get 2 points, then it's immediate immortality, admit to the hospital. And if it's more than it's 3 or more then points, then high mortality, 14 to 40%. So you put them in ICU. Okay, so community acquired pneumonia treatment, high mortality, then treat with. So for this one, you treat it with ceftriaxone and azithromycin, again beta-lactam and macrolide, and admit to hospital. Again, recommended therapy and settings. So for outpatient, it's gonna, if they're healthy patients, then amoxicillin or doxycycline, one or the other. Comorbid condition, they have diabetes or malignancy, then you are going to go with fluoroquinolone or beta-lactam plus macrolide. Okay. If it's inpatient but not ICU, then fluoroquinolone again, or beta-lactam and macrolide. Okay. And if it's inpatient ICU, then beta-lactam again and macrolide, or beta-lactam plus fluoroquinolone. Okay. Uh, Capnography. Okay, water break here. So capnography, it detects CO2. Okay, that's what it does. Um, so when you intubate a patient, and you can check to make sure how much CO2 is detected in the pipe. Okay, that's what this is. And these are the patterns that are usual, and we should know these patterns and what it means. Okay, so normally in the tube, if the line is closer or higher, that means there is high amount of O2. If it's lower, it means there's low amount of CO2. Sorry, not O2. I meant CO2. If there's high, it's a line is a higher. Sorry, again, I'm like zoning out. Sorry. Let's try that again. If the slope is higher, it means there's high amount of CO2, and if it's lower, that means there's low amount of CO2. Okay. We don't need to worry about that stuff. We just look at the patterns. So again, hyperventilation, what's going to happen? There's a carbon dioxide washout, right? So initially you will have a higher amount or higher peak for CO2, and eventually it's going to start getting lower and lower CO2 detection, right? And during hypoventilation, initially it's going to be a lower amount of CO2 detected, but over time it's going to build up, so it increases. Okay. Bronchospasm, it's a weird pattern. It's called a shark fin pattern. Um, right, shark fin if wheezing, bronchospasm. So shark fin pattern is for that. Loss of alpha angle, phase 2 and 3 as well. Okay, so this is shorter. So that's that. Tube displacement. If there's a tube displacement, initially there will be some while you're placing it in. Sudden loss in all phases or reduction of EtCO2, endotracheal CO2. Okay. CPR. If you're giving CPR, it's going to be low amount, but you will detect it. So decrease in EtCO2 due to low cardiac output and perfusion. And then there is apnea. Apnea is going to be, you'll see it, and then there's nothing for absent of phases 0, 1, 2, and 3. Okay. So detect CO2. So what does a flat line mean? It means it's not in the tube. It means the tube is not placed. Flatline means the tube is not placed in trachea. Could also be cardiac arrest, but the history will show that, right? And shark fin is if there's wheezing and bronchospasm. Okay. Hypersensitivity pneumonitis. This is an immunologic response to inhaled antigen. It kind of presents like idiopathic pulmonary fibrosis and asthma, since you hear crackles and history of episodes of such as acute symptoms with high respiratory rate and reduced oxygen oximetry, okay, SpO2. Idiopathic pulmonary fibrosis, or yes, I think that's what it means. Okay, yes. Uh, Idiopathic pulmonary fibrosis happens in more than 50 years of age. It mimics closely to the chronic hypersensitivity pneumonitis presentation as well. Okay, so let's go through that. Hypersensitive pneumonitis. Etiology: immunologic response to inhaled antigen, for example, mold or animal protein. Okay. Acute is going to show up as clinical presentation as abrupt onset fever, chills, cough, dyspnea, fatigue, leukocytosis. Episodes often recurrent and self-resolving. Chest x-ray, scattered micronodular interstitial opacities. Uh, okay, so scattered micronodular interstitial opacities. Episodes often recurrent and self-resolving, so it happens to them often. Um, and abrupt fever, chills, cough, dyspnea, fatigue, leukocytosis. These are all the acute symptoms. And then in chronic, you get progressive cough, dyspnea, fatigue, and weight loss is there as well. Okay, so if they're doing all of this, plus there's weight loss, usually weight loss is, malignancy or something like that related. But here you get weight loss as well, or hypothyroidism, right? So remember, weight loss, now hypersensitivity pneumonitis. Hypoxemia that worsens with exertion. Chest x-ray, diffuse reticular interstitial opacities. Okay, so here you have diffuse, that means all over the place. You have reticular interstitial opacities. Here it's scattered micronodular interstitial opacities. Okay. Diagnosis, pulmonary functional test. Restrictive pattern is seen. So there is decrease in DLCO and chronic only. Bronchoalveolar lavage will have high relative lymphocyte count. Lung biopsy will show lymphocytic infiltrate, poorly formed non-caseating granulomas, interstitial inflammation, or fibrosis if it's chronic only. Okay. Treatment is remove antigen exposure, resolves acute disease. Glucocorticoids, corticoids, and or lung transplantation. It's chronic only. Okay. Uh, bronchiocarcinoid tumor. Okay. Bronchiocarcinoid tumor. And this is one of the from the lung page, lung cancer page from step 1 FA. It I believe it had a different thing that where it said like it kind of looks like tuberculosis, but that's not true anymore. Here, it happens in young patients, around 20-year-olds. It looks look for localized wheezes. Okay. Also, since it's carcinoid, um, diarrhea, dyspnea, and cough. That is a giveaway for that. There will be repeat episodes of pneumonia in the same place. It means that there is a structural lesion inside or around neoplasm, the proximal bronchus. Common in non-smokers, among the other lung cancers, just cancers. Bronchial carcinoid tumor epidemiology, most common lung cancer in adolescent young adults. Neuroendocrine tumor derived from bronchial Kalinske cells. Manifestation here is proximal airway obstruction, that is dyspnea, wheezing, cough, recurrent pneumonia, distal to obstruction, hemoptysis, carcinoid syndrome less common than with midgut carcinoid. Diagnosis, chest imaging, will show contrast enhanced vascular tumor with endobronchial component and bronchoscopy with biopsy. Okay. You have a 2 episodes of pneumonia within the span of 4 months. What do you do? Review of. Oh, okay. So there's 2 episodes of pneumonia within the span of 4 months. Okay. So it's quite recent. Twice in short term. Review of previous episode chest X-ray with the X-ray of recent episode 5 days ago. Now on treatment and feels better. Shows that it happened at the same place as before. Okay, so what is the next best step? Next best step is to do chest x-ray, not bronchoscopy. Why? Because CT scan of the chest typically precedes bronchoscopy in patients with a suspected lung mass. Now that the area has cleared up, you can better visualize if there is one on chest x-ray. Okay. Bronchoscopy is often used to obtain a tissue biopsy when a centrally located lung mass is identified on CT scan. Okay. Hmm. Chest x-ray or CT scan? It's either or. Let's see what it says here. They didn't help. Okay, so I believe that is CT scan of the chest, because that's what it says here. Yeah, that might be wrong. It needs to be CT scan. Okay. Common causes of recurrent pneumonia, bronchial obstruction, neoplasm. You already know these. Okay, so I'm going to skip that. Different lung lobes, immunodeficiency, HIV, leukemia, CVID, that is common variable immunodeficiency, sinopulmonary disease, cystic fibrosis, immotile cilia, non-infectious vasculitis, and BOOP, the obliterans one. Okay, this is important. No, no. Okay, so this pretty much all that. QID 4087, and that I saw this extremely high yield question for USMLE, so I thought I would put that in just like that because that's the first time I saw them write something like this, so it's probably really important, I think. Undiagnosed pleural effusion is best evaluated with thoracocentesis, except in patients with clear-cut evidence of congestive heart failure. Okay, so thoracocentesis is important to remember for undiagnosed pleural effusion. Idiopathic pulmonary fibrosis. This is normal CT scan. That's what it looks like. Nice little peaceful chest. And here we have diffuse interstitial parenchymal opacities. Uh, a lot of stuff happening here. It's all messed up. It's like a party in here compared to this. Clubbing can be seen in interstitial lung disease as well. You will see restrictive pattern in this and increase in alveolar arterial gradient, AA gradient. Okay. We already went through this, but again, modified Wells criteria for pretest probability of pulmonary embolism. Okay. Um, let's take a break here. I'll go through this after the break. Drink water. See you soon. All right. So we're going to be talking about modified Wells criteria for pretest probability of pulmonary embolism. Right. This is what the algorithm was. If PE is unlikely, you do D-dimer. If it is likely, you do CT scan, and if it's positive, it's confirmed. Right. Okay. So if you have 3 points, um, clinical signs of DVT, alternate. Uh, for 3 points, if you have clinical signs of DVT and alternate diagnosis, less likely than PE. For 1.5 points, you need to have either of these three: previous PE or DVT, heart rate more than 100, recent surgery or immobilization. And then for 1 point, if they have hemoptysis or cancer. Total score here, if they have more than 4, it's likely that it is PE. If it's 4 or less, then it's PE is unlikely. Okay. Approach to patient with suspected pulmonary embolism. Stabilize patient with oxygen and IV fluids, and then evaluate for absolute contraindication to anticoagulants. If they have absolute contraindication to anticoagulants, then obtain diagnostic test to evaluate for PE. If it is positive, then consider IVC filter. If it's negative for PE, then no further evaluation is needed. If there are no contraindications to anticoagulants, then you first assess clinical suspicion of PE with modified Wells criteria. This thing right here. If it is likely, then consider anticoagulation, especially if patient has no relative contraindications or moderate to severe distress. Um, and then obtain diagnostic test to evaluate for PE. If PE is unlikely, again, obtain diagnostic test to evaluate for PE. Okay. Um, so if it's less than this, you still do this. But if we got 4 or more, Then we go straight to anticoagulation first, and then we continue with the diagnostic tests. So obtain diagnostic test to evaluate for PE. If it's negative, you don't have to worry about it. You can stop anticoagulation. However, if it is positive, you start or continue anticoagulation and consider surgery or thrombolytics if indicated. All right, moving on. Assessment of malignancy risk for solitary pulmonary nodule here. Um, let's do the algorithm first. So you have a solitary pulmonary nodule on routine chest x-ray. Okay, so it was an incidental finding. What do? You ask for previous chest x-ray records and then you compare them. If stable lesion over 2 to 3 years, no further testing is required. However, no previous imaging or possible nodule growth is seen, then you do CT, chest CT. Okay, not X-ray. You do chest CT. If you have benign features, you do serial CT scans. If it is indeterminate or suspicions of malignancy, further investigation with biopsy or PET. Okay, PET scan. And if highly suspicious of malignancy, surgical excision. Okay, so what's a low risk for these solitary nodules? If the nodule size is less than 0.8 or the age is 40 or lower, smoking status is that they have never smoked or they have stopped smoking for over 15 years, or nodule margin characteristic is smooth. Intermediate risk is that the nodule size is a little larger, 0.822 centimeters, age is 40 to 60, smoking status is current, or smoking cessation is 5 to 15, right? So 15 years or less. And normal margin characteristics are scalloped. And high risk is 2 centimeters or more in size. Sorry. Age is more than 60. Smoking status is current. Smoking cessation year is 5 or less. And nodule margin characteristic is corona radiata or spiculated. So solitary lesion, 3 centimeters diameter, surrounded by pulmonary parenchyma. There is no atelectasis, pleural effusion, adenopathy. If there is an incidental finding, first step is to compare it to previous x-rays. If there is none available, do CT scan of chest. Okay. Chlorpheniramine. It is an H1 histamine receptor antagonist. Two most common cause of chronic cough. Okay. One is postnasal drip, upper airway cough syndrome associated with allergic rhinitis, and asthma and GERD. Okay. Should be 3 then? I know. Okay. The diagnosis of upper airway syndrome is confirmed by the elimination of nasal discharge. Okay. So when you're trying to figure out what the chronic cough is because of, first we gotta take care of the postnasal drip. This is upper airway cough syndrome. It's associated with allergic rhinitis. Okay. So how do we do that? By elimination of the nasal discharge and cough using chlorpheniramine or any of the H1 histamine receptor antagonists. If they're on this and it goes away, then this is what the cough was caused by. If it still persists, then it's probably one of the other reasons of chronic cough. Okay, you have a patient that's 72-year-old, flat neck veins, uncompensated BP from sitting to blood pressure from sitting to standing. Okay, so this is hypovolemia, salt and water depletion, baroreceptor sensitivity. This is an autonomic failure. Decreased urine serum sodium decreased urine sodium is a sensitive indicator of hypovolemia. Okay, you will have a decreased amount of sodium in your urine in hypovolemia, unless taking diuretics or has significant renal impairment. How does it happen? Hypovolemia leads to decreased renal perfusion, which leads to RAS system activation, which leads to aldosterone increase, which leads to aggressive sodium reabsorption in the collecting duct, and that causes decreased urine sodium. Okay, so these are your likes criteria, right? Exudative, pleural fluid protein over serum protein ratio is more than 0.5. Pleural fluid lactate dehydrogenase LDH over serum LDH ratio is more than 0.6. Pleural fluid LDH more than 2 over 3 of the upper limit of normal serum LDH. Common cause of pleural effusion, again, um, transidative is going to be congestive heart failure, cirrhosis, nephrotic syndrome, peritoneal dialysis. Exudative is infection, malignancy, connective tissue disease, inflammatory disorder, movement of fluid from abdomen to pleural space, coronary artery bypass surgery, and pulmonary embolism, usually. Okay, so normal pleural pH, okay, we are talking about pH, it's 7.6. Okay, transitive pH is going to be 7.4 to 7.55. Okay, and exudative pH is a little lower. It goes down to 7.3 to 7.45. Okay, so 4.5. So between 7.4 to 7.45 is overlapping between the two. Okay, so if we were to go from 7.3 to 7.55, 7.45 is right in the middle, and both of those will have it. Okay, I'm just trying to memorize this. Okay, so exudative is on the lower end, 7.3 to 15 more, and 7.4 to 15 above. Okay, pH less than 7.3 with normal arterial pH and low pleural glucose is usually empyema, because it increases acid production by the pleural cells and bacteria. It could be pleuritis, tumor, pleural fibrosis, decreased hydrogen ion efflux from the pleural space. Transidative glucose is same as body glucose. Okay, so if it's decreased less than 60, it is seen in parapneumonic effusion, malignancy, TB, and rheumatoid arthritis. Okay, so aspirin exacerbated respiratory disease, or AERD. Okay, so basically this is when they're taking aspirin, so the aspirin blocks out this pathway, COX-1 and COX-2, which makes prostaglandins and all of these things. So if this is gone, this thing goes through the 5-lipoxygenase pathway to make leukotrienes, and leukotrienes eventually causes bronchospasm, and that causes the aspirin exacerbated uh, res- respiratory disease. So NSAIDs, ARD should be suspected when the Samter triad is present. So what is the Samter triad? It's asthma, for example, intermittent wheezing, chest tightness, chronic rhinosinusitis, for example, nasal congestion, frontal headaches with nasal polyps, NSAIDs induced respiratory reactions, for example, worsening symptoms after over the counter analgesics, for example, ibuprofen. ARD triad occurs due to imbalanced production of leukotrienes over prostaglandins. Okay, so you have a hand with uh, dark fingertips. Um, looks like gangrene or something like that. Okay, so this finding is in a patient with septic shock after giving empiric treatment plus norepinephrine. Okay, So what happened here was norepinephrine is vasopressor, which causes profound vasoconstriction, and that leads to ischemia of peripheral structures, including digital tissue. Okay, so that's because of that norepinephrine. Indication for initiating long-term home oxygen therapy. Okay, so what is an indication for this? We sort of talked about this already. If the pulse oximetry saturation is less than 88% or less, or arterial oxygen tension is 55 mmHg or less, okay, at rest, with normal exertion or during sleep, right? So we talked about this when we were talking about treating COPD. First one is smoking cessation, and then if there's 88% or less on pulse ox, then supplement it with oxygen. So this is long-term oxygen therapy if you find these findings during exertion or during sleep arrest. Right. Patient on methotrexate has shortness of breath after starting treatment for rheumatoid arthritis. Next best step, well, just continue methotrexate. MTX induced lung injury. Okay. Um, onset is 1 to 12 months. So it doesn't have to be recent. It could be over 6 months, 7 months, up to 12 months. Pneumonitis fibrosis. CT scan will show with scan with variable mix of patterns, inflammation, and fibrosis. Bronchoalveolar lavage, lymphocytosis, peripheral blood, eosinophilia. Okay. So BAL will show lymphocytosis, peripheral blood, and eosinophilia. Methotrexate causes lung injury. That's the main takeaway. And it will show up on CT scan as inflammation and fibrosis. So this thing right here, this is superior pulmonary sulcus tumor or Pancoast tumor. This is what it looks like on MRI. Okay, tumor in the right superior sulcus, pulmonary apex. Okay, so that's the odd finding right there. Common manifestations of superior pulmonary sulcus tumor is shoulder pain, Horner syndrome. This is invasion of paravertebral sympathetic chain stellate ganglion, uh, ipsilateral ptosis, meiosis, enophthalmos, and anhidrosis. Neurologic symptoms in the arm, invasion of C8 to T2 nerves, weakness, atrophy of intrinsic hand muscles, pain paresthesia of 4 and 5th digits and medial arm, forearm, supraclavicular lymphadenopathy, and weight loss. Okay. How much is left? We are at 18 out of 30. Okay. You have pleural effusion plus low pleural glucose. Okay, so again, we already talked about this. If you have pleural effusion and low pleural glucose, that means you have empyema. Empyemas are exudative effusions with a low glucose concentration due to the high metabolic activity of leukocytes and bacteria within the pleural fluid. COPD patient plus exacerbation, and they have SpO2 of 84%. Then gave supplemental O2 as one should, inhaled bronchodilators, and systemic corticosteroid, and SpO2 is now at 98. After 30 minutes, patient became unresponsive and had seizures. So what was wrong here? Well, this is called O2-induced hypercapnia. Okay. Um, when you give O2 supplement, the target SpO2 for you is 88 to 92. You keep it at the lower end, so it can be prevented by maintaining a saturation of O2 at 88% to 92%. Okay, because of all these effects. Okay, so major effect is that there is pulmonary vasoconstriction at first, and then you give O2, then what happens is vasodilation diverts blood from well ventilated regions, and This causes increase in alveolar dead space. Okay, and that will increase your PaCO2. Okay, because this damage, the unresponsiveness and all that is because of the hypercapnia. Okay, another moderate effect is that at baseline, high AGB affinity for CO2. After administration of 2, there's decreased AGB affinity for CO2, Haldane effect. This causes increase in dissolved CO2, and that too will increase PaCO2. And the minimal effect is that peripheral chemoreceptor stimulation at baseline is happening, but after O2, that thing stops. There's decrease in chemoreceptor stimulation, so now you have decrease in ventilation as well. So manifestation of hypercapnia are mainly neurologic and include headache and somnolence. Hypoxemia may be absent. Therefore, high clinical suspicion is required to recognize hypercapnia and measure PaCO2 using arterial blood gas analysis, ABG. All right. Different question. Moral of the story was patients with severe acute exacerbation of chronic obstructive pulmonary disease, for example, hospitalized patients, should be treated with empiric antibiotic, for example, fluoroquinolone, third generation cephalosporin, and targeting commensal respiratory bacteria. Okay. All right. 50-year-old, 50 to 70-year-old, so say 60-year-old, plus dyspnea, dry cough, frank crackles, no history of smoking, was in the Navy. Another question worked in this was about where the patient worked in home insulation and plumbing company, plus history of asthma. Okay. So, what would the findings for total lung capacity, FEV1 be, FVC ratio be, and diffusion capacity of carbon monoxide be? Okay. So this is, it seems like it's asbestosis. Okay. So asbestosis causes interstitial lung disease. Okay. So you'll have decreased total lung capacity. Okay. You'll have normal FEV1, FVC ratio. Um, it's all restrictive pattern, right? So that and diffusion capacity for carbon monoxide is going to be decreased because of the inflammation and destroying the alveolar walls. Okay, so DLCO is decreased, normal, and TLC. Okay. Uh, this is just to go off of that. Classic pulmonary function patterns, abnormal FEV1C. If it is decreased, it could be either of these. If it's preserved, like it is in this case, um, then it's restriction, decrease in lung volumes, which leads to alveolar membrane. It could be either thickened, which causes decreased DLCO, so it is parenchyma, ILD, intrinsic restriction. It could be intact, then it is you will have normal DLCO, then it's extrinsic restriction, like chest wall, kyphosis, or neuromuscular disease. Okay, if it is decreased, less than 0.7, obstruction, it is obstruction, and there's an increase in lung volume. This could be either reversible or it could be not reversible. If it's reversible with beta agonist, then it's asthma. If it's not reversible with beta agonists like bronchodilators, alveolar membrane is either destroyed or intact. If it's destroyed, it's emphysema. And if it's intact and with normal DLCO, then it is chronic bronchitis. Okay, so here we're talking about idiopathic pulmonary fibrosis. Answer A. Other things seen with this is an inspiratory squeaks, digital clubbing, abnormal S2, loud P2, fixed or split S2 due to pulmonary hypertension. This is verbatim from the QBank. Evaluation should include a thorough history to identify evidence of autoimmune disease, use of associated medication, for example, amiodarone, occupational exposures, and therapeutic radiation. For example, this patient's long career in the Navy have places him at increased risk due to asbestos exposure. Chest X-ray typically demonstrates non-specific reticular infiltrates, but chest CT findings such as peripheral or basilar reticular infiltrates and honeycombing are more helpful in establishing the diagnosis. If imaging is non-diagnostic or the clinical picture is atypical, a biopsy can confirm the diagnosis. Clinical features of asbestosis is prolonged asbestos exposure, shipyard or mining. Symptoms develop more than 20 or more years after initial exposure. Progressive dyspnea, basilar fine crackles, clubbing, increased risk for lung cancer and mesothelioma. Diagnostic evaluation, pleural plaques on chest imaging PFT, and histology consistent with pulmonary fibrosis. Okay, this is the loop for this, right? From first aid, step one. Uh, Normal is more than FEV1 is more than 80% predicted. That's normal. So if they say 96% of predicted or 97% or 84%, is still normal FEV1. FVC same thing, 80%, but FEV1 over FVC, this is the number you have to remember, 70%. Because if they tell you that it is lower than 70%, then it's going to be obstructive. If it's 70% or more, it's restrictive, right? RV, FRC, and TLC is all increased in obstructive, where it's decreased in restrictive lung disease. FEV1, FVC is decreased in both. However, the ratio is decreased only in obstructive, and it's normal and increased in restrictive. Okay, everything is decreased in restrictive lung disease except for FEV1 over FVC. If you remember this chart like this, the first three increase and the last three decrease for this. So we went over this during the FA read for step 2. Okay, you have a patient that's confused between you have a vignette and you're confused between if it's exercise induced asthma or COPD. Plus there is hypercalcemia. So because of this, you choose sarcoidosis. It is okay. There's a history where you have a 45-year-old patient with coughing plus wheezing and other things. Okay, so you have coughing, wheezing, and other things. It's pointing to causes could be due to ACE inhibitor of leukotriene induced vasoconstriction. Since they gave okay, got it. So the question was that there was a 45-year-old patient with coughing plus wheezing and other things that was there as well, and then they told you that there is they give you this finding that they checked before they gave the bronchodilator and then they checked afterwards. So what happened? The FEV1C FEC, sorry, in liters increased, right? It went from 86% predicted to 90%, so it got better. The FEV1 went from 61% to 84%, so that got better. FEV1 went from 58% to 70, the normal, that got better. DLC was 94% of predicted, normal is more than 80, so that was normal already. So what does this tell you? That the bronchodilators work. And when does it work? When it is asthma, right? Bronchodilators have no effect on COPD patients. Okay, so it's pointing to causes could be due to ACE inhibitors of leukotriene induced vasoconstriction. Okay, since they gave pre-bronchodilator results and post, we can see that there is an improvement, and therefore we can rule in favor of asthma. COPD does not respond to bronchodilators. Okay, this is the chart between asthma, COPD, and late stage COPD. FVC here, it's normal, decrease, normal, and decrease in this. Late stage COPD is decrease. FEV1, again, same thing. The ratio is same thing. Bronchodilator response, it's reversible in asthma, but not reversible in COPD. Chest X-ray is same, and DLCO, it could be normal or it could be increased in asthma because of inflammation, or it could be decreased in COPD. Okay. Sorry, not inflammation. It doesn't happen here. It's normal or it's increased. But however, it is decreased because of the mucus plugging and what else? All that stuff. Okay. Um, History of recent intubation. Late stage COPD, I don't think they differentiate between the two. But hyperinflation, loss of lung markings, it's usually non-reversible, and DLCO is decreased. Okay. History of recent intubation or mechanical ventilation, 92 months ago. Okay, so this patient had a history of recent intubation or mechanical ventilation, and this one had it 92 months ago. 92? No, that's a weird way to say it. It's just 2 months ago. Okay, and now has a noisy breathing or stethoscope. Okay, and when they did the flow volume chart or loop, this is what they got. Okay, so what is this? During inspiration, it was blunted, and during inspiration, it was blunted, and during expiration, it was blunted as well. And the response. So this is called tracheal stenosis. It is due to scar formation from the previous intubation or mechanical ventilation, scratching and injury or whatever. So this reduces airflow during inspiration and expiration, causing flattening of the flow volume loop. Okay, so normal response is this one in gray. During expiration, it goes um, flow goes up to here and then down again to 0, and then during inspiration it goes down here and like that. But since there is a stenosis, tracheal stenosis caused by the whatever scar tissue, you get blunting response over there, and it's noisy breathing because of that. Okay. So inspiratory and expiratory flow equally restricted. Lung volumes are unchanged. This anterior mediastinal mass, like goiter, tracheal or subglottic stenosis, or vascular ring, can cause this. Now, water break. Okay. Um, so ventilator settings are as follows. Currently, tidal volume is 370 ml. They kept the 6 ml kg of ideal body weight, so it's good. Respiratory rate is set at 22 per minute. Positive and expiratory pressure is 5 centimeter H2O. F5O2 is at 70%. Inspiratory plateau pressure is normal, less than 30 centimeter H2O. Okay. Chest X-ray reveals extensive bilateral alveolar opacities. The results of arterial blood gas analysis are as follows. pH is 7.44, PaCO2 is 30 mmHg, PaO2 is also 53 mmHg, HCO is also low. Okay. Which of the following is the best next step in management of this patient? Okay. So this is how we go about it, right? If it's intubated, initial ventilatory settings. Okay, so tidal volume is already set at the correct amount. Respiratory rate, we want it lower, right? 22 per minute. But since uh, this is low, right? PaO2 is, I believe, low. Let me get those stats for you. Give me a sec. Okay, so we got this now. Um, so pH is in the normal range. PaCO, however, is a little low. PO2 is also low. So we have low carbon dioxide in the body. PO2 is also low. Low amount is coming in, and HCO3 is also low. So it is acidosis, sort of, right? Metabolic, I guess, or yeah. Okay. So tidal volume is a normal. Respiratory rate is 22 per minute. Okay. Um, which is on the higher end. However, that is still causing low PaO2, even though we have high amount of respiratory rate. PEP is 5 centimeters, right? Uh, I believe we can go up to 10. Okay. FiO2 is 70%. We need it lower than 60. But however, since this is low, we don't want to decrease that right now. We'll leave it at that. Inspiratory plateau pressure is normal. Okay. So there's um, no decreased compliance, right? Uh, chest X-ray reveals. Wait, no, sorry. There's increased inspiratory resistance. Right? Where was that? This one, right? If you have normal plateau, you have increased resistive airway pressure. Okay. Hmm. Okay, so there's that. Chest X-ray reveals extensive bilateral alveolar opacities, and these are the results. Okay, so which of the following is the best next step in management of this patient? So if we go along this algorithm, let's see where we end up. Intubation and initial ventilator setting, oxygenation is FiO2 is 100%, and PEP is 5 centimeters H2O. Ventilation is set as 6 ml per kg, IBV, IBW, and respiratory rate is between 14 to 18 per minute. Okay. Over the time they adjusted, and this is where they ended up. So now, if you adjust oxygenation, when do you do it? If PaO2 is more than 90, which it is not, you would decrease the FiO2. Okay, and if it is less than 60, which it is, you are going to increase PEEP. Okay, and if you had to adjust ventilation, you're going to check if there's increase in PaCO2, which it doesn't have, right? And the pH is less than 7.2, okay, 7.25. If it's less than that, which it isn't, you would have increased the RR or increased the VT, which is tidal volume, as last resort. Or if there is decrease in PaCO2, which there is, and pH is more than 7.45, which is not. So we don't do this because it doesn't meet this criteria right here, 7.45. You would have decreased the tidal volume, decreased the respiratory rate, and increased sedation as last resort. Okay. So here the answer would be increase in PEEP. Okay. Ensure lung protective ventilation. Avoid alveolar overdistension. That is your main goal. Okay. When you're doing increase in PEP. Evaluate lung compliance. Measure P-plat with inspiratory hold. Goal is that P-plat is 30 centimeters H2O or less, and decrease in tidal volume and or adjust PEP. Okay, so that's what you would have done. But we don't do this because this is not increased and this is in the correct range, 7.45. Okay, because it goes from 7.35 to 7.45. So it is in the normal range. Okay. All right. On to this. Daytime sleepiness. Involved in accident due to dozing off while driving. Okay, so dude was driving. He stopped at a red light, stop sign, and then he let go of the brake, and then it went into a stop sign or something like that. I forget. There is an increase in blood pressure as well. Okay, so they have hypertension plus they have daytime sleepiness. This all points to OSA. Okay, uh, sleep apnea, obstructive sleep apnea. Obesity, hypoventilation syndrome plus obstructive sleep apnea will cause chronic hypoxia, hypercapnia with a compensatory metabolic alkalosis, secondary erythrocytosis, pulmonary hypertension, core pulmonale are all of these things can occur with OSA. Okay, main thing you gotta see that the systolic is high and there's daytime sleepiness. They all point to OSA, and then these things just fall into place. You get decreased chloride due to retention of bicarb. Okay, why? You have bicarbonate because of chronic hypoxia and increased hypercapnia, I guess. Wait, acidosis. Yes, so you get acidosis. So you're gonna start retaining bicarb to level that out, and because of that, since it is in equilibrium with chloride, you will have decreased chloride. Okay. uh, Pulmonary arterial hypertension, group 1 pulmonary hypertension. Etiology is idiopathic, connective tissue disease, toxin, HIV, cystomyosis. Clinical presentation is fatigue, exertional dyspnea, syncope, pre-syncope. Examination would be loud P2, wine S2. This you should know from step 1 that if there is loud anything, it has to do with the pulmonary aspect of the artery, or is it the artery at the vein? Okay. Uh, the right ventricle heave. There is right ventricular heave, yes. Right-sided S3 and S4, tricuspid and or pulmonary regurgitant murmur, JVD, ascites, peripheral edema, and hepatomegaly. Pulmonary arterial hypertension is a common complication of limited cutaneous systemic sclerosis, or the CREST syndrome. It CREST, calcinonin, gnosis, Raynaud's. E was for something. T was for some sclerodactyly. That's what that was. E was for esophageal dysmotility, and T was telangiectasia, I think. Okay. It typically presents with progressively worsening dyspnea and may lead to right ventricular enlargement and right-sided heart failure. It leads to arteriolar intimal hyperplasia seen in lung biopsy. Okay, so that's what pulmonary arterial hypertension will lead to. Arteriolar intimal hyperplasia. Okay. Right ventricular enlargement and right-sided heart failure is also seen in this. Okay, it is a common complication of cutaneous systemic sclerosis. Okay. Classification of hyponatremia. So there's just going over the findings. We don't need to really go through it because it is there, but we will because we want to be thorough. Serum osmolality formula is this. You don't need to know it. I just put it there. 2 times sodium plus serum glucose divided by 18 plus serum BUN divided by 2.8 is equal to serum osmolality. What you will get is euvolemia. Um, Okay, so if it's euvolemia, it's because of the question. This wasn't the question right here. I think I was zoned out when I wrote this. For example, moist. So if it's euvolemia, this is what you'll see: moist mucous membrane, absence of jugular venous distension. Uh, Euvolemic is consistent with the syndrome of inappropriate antidiuretic hormone secretion. Okay, so see, same thing you'll find here. Hypertonic, so increase amount of fluid but a low amount of serum, sodium. Okay, so it could be either increase amount of water or low amount or the perfect amount of water volume. Okay, so if you have low volume and your sodium finding is that there is decreased amount in urine, it's non-renal salt loss, so it could be diarrhea or vomiting. Okay, that's why you have a low amount of that. If you have a lot of sodium coming out, it could be because of renal salt loss, like you're taking diuretics or primary adrenal insufficiency. Okay, uh, where you have decreased amount of aldosterone. If it's euvolemic, then your urine osmolality is low. Okay, it's lower than 100 uh, milliosmol per kg. You have primary polydipsia, a lot of water and low amount of sodium is in the urine, right? Or beer potomania. What is potomania? Oh, it doesn't work in this. Mm, well, let me know in the comments. Uh, if euvolemic, urine osmolality is more than 100, okay, and urine sodium is more than 40, it's usually SIAD, inappropriate secretion of antidiuretic hormone. Okay, hypervolemic. Okay, so you have a lot of water, and that's what's causing the hypertonic uh, osmolality. Then it is urine findings going to be variable. It could be due to heart failure, cirrhosis, or nephrotic syndrome. If serum osmolality is isotonic or hypertonic, which is more than 295 milliosmol per kg, your findings are going to be variable. And what causes it? The isotonic is caused due to pseudohyponatremia, for example, paraproteinemia or hyperlipidemia. Or if it's hypertonic, it could be because of translocation hyponatremia, for example, hyperglycemia, exogenous solutes like mannitol. And water break right there. Okay. Um, right. Okay. Sorry about that. Okay. So we have a patient with a history of ischemic heart disease, uh, dry cough, exertional dyspnea, and inspiratory crackles, fine and dry. The fine and dry are actually inspiratory Velcro crackles. Okay. Negative history they gave is normal jugular pressure, no peripheral edema. Okay, so we don't have edema, normal pressure, jugular, ischemic heart disease, history of it. There's dry cough, exertional dyspnea, and there are inspiratory crackles. This is a buzzword for inspiratory Velcro crackles. They should be evaluated for interstitial lung disease. Velcro crackles are sensitive for interstitial fibrosis. Okay, so now don't forget that. write it somewhere. Uh, that inspiratory crackles that are fine and dry are called Velcro crackles, and Velcro crackles are sensitive to interstitial fibrosis. How do you diagnose it? So you are going to do HRCT scan or high resolution CT scan in prone position to prevent atelectasis and better see the reticulation or honeycombing. Early disease progression won't show up on chest x-ray. Okay. After treating acute exacerbation, leukocytosis is seen. Okay. So they treated acute exacerbation and now they have leukocytosis on the lab work. It's because glucocorticoids cause a leukocytosis mainly through mobilization or migraine, marginated neutrophils and an increase in number of circulating neutrophils. So that's why it's a normal finding after giving steroids. Dyspnea on exertion and persistent cough, South Asia 10 years, palpitations plus enlarged cardiac silhouette, plus crackles on lung auscultation, plus irregular heart rhythm, sorry. So that's uh, AFib, right? We have AFib, crackles on lung auscultation, enlarged cardiac silhouette. So that's either hypertrophy or decompensated heart. Palpitation, uh, South Asia for 10 years has been there. Dyspnea on exertion and persistent cough. Okay. So this all points to rheumatic heart disease, and you get mitral stenosis in that, so that will cause crackles on lung auscultation as well. Okay. So albuterol leads to hypokalemia. Okay. This leads to clinical features seen in this chart. So I remember first one we did was methotrexate, then chlorpheniramine, and now albuterol has some kind of significance uh, leading to all of these. Okay. All right. So etiology for hypokalemia: diuretic thiazide, vomiting, diarrhea, hypomagnesemia, hyperaldosteronism, increased beta adrenergic activity, for example, albuterol. Clinical features: muscle weakness and cramps, hyperreflexia, rhabdomyolysis, cardiac palpitations with or without arrhythmia. Okay. Or cardiac palpitation and or arrhythmias. Okay. Okay. So I believe I finished clinical features. ECG findings are going to be broad, flat peak waves or prominent U waves, right? Hypokalemia. Treatment here is potassium replacement. Tension pneumothorax. What do you see? Acute onset of shortness of breath, pleuritic chest pain, hypotension, unilateral absent breath sounds. Here, diagnosis is chest x-ray. Pulmonary embolism. What do you see? Similar findings as tension, right? Commonly associated with atrial fibrillation. That's not there, but here. It is a commonly associated with atrial fibrillation, okay? Sudden onset of shortness of breath, like this one. Pleuritic chest pain, like this one. Tachypnea, um, maybe this one. Tachycardia, hypoxemia, low grade fever. This is important because that's an odd finding, or you wouldn't think about it, right? Unless you know about it. And jugular venous distension. There will be high alveolar arterial gradient on arterial blood gas, and it happens due to immobilization, like in wheelchair as well. Okay. Asthma. Treatment of an acute asthma exacerbation includes a short-acting bronchodilator, right, albuterol, to manage immediate bronchoconstriction, and a systemic glucocorticoid, like prednisone, to dampen the late phase inflammation and prevent symptom relapse over it is usually a short course of glucocorticoids. Sometimes the treatment takes time to work, and the high respiratory rate can cause fatigue in muscles, which is evident via ABG. Okay, we talked about this. A normal or elevated PaCO2 is an alarming and extremely important finding that suggests impending respiratory failure. Okay, so what do we do in this case? Intubate in that case, or non invasive face mask to bridge the gap between the treatment, which is short acting bronchodilator and glucocorticoid, to work and exacerbation. Okay, cor pulmonale refers to isolated right sided heart failure from pulmonary hypertension, most commonly due to chronic obstructive pulmonary disease. Okay, so from pulmonary hypertension, most commonly it is due to COPD. Signs of right-sided heart failure include jugular venous distension, increased intensity of P2, pulmonary component of the second heart sound, right ventricular heave, hepatomegaly, dependent pitting edema, and possible ascites. Okay, cor pulmonale again, same thing. Um, I don't think we need to go through this anymore. We already covered. I'll cover the etiology. So RV failure due to pulmonary disease and resulting pulmonary hypertension, chronic hypoxia, vasoconstriction, COPD, ILD, OHS, um, pulmonary thromboembolic disease, and absence of left-sided heart failure. Okay, so chest imaging reveals increased right lower lobe infiltrate. Okay, right pleural effusion. Okay, right-sided hilar adenopathy compressing the middle lobe bronchus. What is the most common likely cause of this patient's condition? Is it lymphoma, sarcoidosis, or TB? Right. So in lymphoma and sarcoidosis, it is bilateral rather than unilateral lymphadenopathy. Here we have right-sided lymphadenopathy. Sarcoidosis is associated with patchy reticular pulmonary infiltrates, and classically it is seen in young adults. Whereas tuberculosis, several weeks of fever, cough, and pleurisy is seen, sometimes pleural effusion. Suspicion should be raised in those residing in high risk settings or have impaired immunity. Okay. Treatment of common pulmonary diseases like pneumonia does not improve symptoms. So if you have tried um, giving antibiotics because of pneumonia, it didn't improve the symptoms even after a week or two, then it's usually you should be suspecting TB. Okay. Quetiapine, atypical antipsychotic medication. It is okay. Um, it so this medication increases the risk of CAP in elderly patients. It may be due to anticholinergic and antihistamine effect of the drug, which reduces the ability to form a food bolus and increase the risk of aspiration. Okay, so anticholinergic, so it dries out the mouth. That leads to difficulty in forming food bolus. That leads to increased risk of aspiration. Okay, risk of factors for CAP or community-acquired pneumonia, impaired immunity, is an age more than 65, HIV or diabetes mellitus, impaired pulmonary function, COPD, bronchiectasis, cystic fibrosis, recent upper respiratory viral infection, smoking, increased microaspiration, substance alcohol use disorder, seizure disorder or stroke, esophageal dysmotility, medications, acid suppressants, sedatives, and immunomodulator agents, acute benzodiazepine intoxication, causes decreased central respiratory drive. Okay, so when you have benzos on intoxication, what it does, it causes decreased central respiratory drive, leading to hypoventilation and respiratory acidosis. CHF versus COPD. This is hypocapnia and CHF and hypercapnia and COPD. Okay, that's the difference. There is hypocapnia, decreased CO2 in this, and increased CO2 in COPD. Elderly prednisone use with community acquired uh, pneumonia and chest x-ray is normal. So what's happening here? In elderly with immunosuppression, which in this case is due to prednisone use, you should do CT scan of the chest as they may have normal imaging of for lung infection despite having signs and symptoms that localize infection to the lungs. Okay, so go for a CT scan instead of this, even though you have a clear or normal chest x-ray. In chest x-ray, you have 2.5 centimeter irregular nodule in the peripheral right upper lung field with no hilar or mediastinal lymph node enlargement. And they have never smoked. Again, you know this from step one, right? This page where they went through all of these, and adenocarcinoma was most common subtype in people who do not smoke, right? I won't go through all of that. I'll just go through this. So tumor type, adenocarcinoma, 40 to 50% incidence. Location is peripheral. All the S's ones are central, right? Squamous central, small central. Okay. Classical clinical association for adenocarcinoma is clubbing, hypertrophic osteoarthropathy. Squamous cell carcinoma, hypercalcemia, and necrosis and cavitation. Small cell carcinoma is Cushing syndrome, CL, Lambert-Eaton syndrome. Large cell carcinoma is associated with gynecomastia and galactorrhea. Okay. You have a neutropenic patient with coughing, small amount of red blood, 3-day fever, pleuritic chest pain, cough productive of thick brown sputum and right-sided crackles. Plus, you have chest x-ray that shows a dense right upper lobe infiltrate which has grown in size when compared to x-ray from 2 days ago. CT scan of chest, severe nodular lesions with surrounding ground glass opacities in right upper lobe, sputum gram stain. You have seen inflammatory cells but no organisms. Which of the following is the most likely diagnosis? TB or invasive aspergillosis? Okay. So which one does it seem like? TB or invasive aspergillosis? So reactivation of pulmonary tuberculosis commonly occurs in patients with immunosuppression and may manifest with fever, hemoptysis, dyspnea, and upper lobe pulmonary disease. However, thick sputum and nodule with surrounding ground glass opacities are more characteristic of aspergillosis. So invasive aspergillosis primarily affects immunocompromised patients and typically causes a triad of fever, pleuritic chest pain, and hemoptysis. Okay. CT scan often reveals pulmonary nodules with surrounding ground glass opacities. Um, so okay, reveals pulmonary nodules with ground glass opacities. Halo signs. It's called okay. Treatment is usually requires a combination of voriconazole and a echinocandidin or caspofungin. Okay, antifungal. Okay, so what is this? This is bronchiectasis. Okay, we already know what that is, so I'm not going to go through that. Bronchiectasis causes permanent. You can pause and read that if you want to. Okay. Bronchiectasis causes permanent bronchial dilation due to recurrent cycles of infection and inflammation. Hallmark symptoms include chronic copious thick sputum production, episodic hemoptysis, and recurrent exacerbation with mucopurulent sputum. Bronchiectasis is diagnosed based on high resolution CT scan of the chest. Okay. Actually, let's go through it. It is important. So, clinical feature pathophysiology, airway insult, for example, infection, inhalation with impaired clearance, mucostasis, immunodeficiency. Clinical features: chronic, daily production of voluminous, thick, with or without blunt tinged mucus, acute exacerbations, recurrent infections with mucopurulent sputum, with or without frank hemoptysis. Okay. Etiology or contributory conditions: airway obstruction, cancer, foreign body, and mucostasis, immunodeficiency, autoimmune inflammatory disease, chronic past infections or toxic inhalation, evaluation, HRCT, scan of the chest needed, a pulmonary function test, and investigation of etiologies with Ig levels, respiratory cultures, and bronchial obstruction. PFT will show obstructive pattern. Treatment: address underlying disorder, Ig replacement, for example, airway clearance, chest physiotherapy, mucolytic antibiotics to suppress bacterial overgrowth and treat exacerbations. Okay, my OCD to be perfect. Hmm. Septal binding with hemosiderin loaded macrophages. This is characteristic of pulmonary edema due to left sided heart failure, which can cause pulmonary hypertension. You have fever, shortness of breath, dry cough, and erythematous rash. Symptoms begin 3 to 9 days from nitrofurantoin initiation. Bilateral basilar opacities and pleural effusions are common finding in this patient. So, acute nitrofurantoin induced pulmonary injury is due to hypersensitivity. Treatment involves cessation of nitrofurantoin. This is a UTI uh, medication. Leukocytosis, eosinophilia. Okay. You it could is seen, I guess. Okay. So you have leukocytosis, and this is due to eosinophilia. You have an Alzheimer's patient uh, who has pneumonia. Why? Because they have trouble with swallowing mechanism. Alzheimer's patients are prone to this. They have trouble with swallowing mechanism, so pharyngeal dysphagia, which may cause aspiration due to insufficient closure of the airway during swallowing. Usually bedridden, so CAP near the posterior portion of the right upper lobe or superior portion of the lower lobes. Acute pancreatitis patient plus difficulty breathing. Management of acute respiratory distress syndrome (ARDS) involves mechanical ventilation to provide adequate oxygenation and ventilation without causing further injury to lungs. Low tidal volume ventilation is a lung protective strategy that reduces alveolar overdistension to decrease mortality in patient with ARDS. Prone position also decreases mortality, likely by homogenizing ventilation throughout the lungs. Okay, again, this was acute pancreatitis patient who had difficulty in breathing, and the chances are that they have ARDS. So what are we gonna try to do? We're gonna try to do low tidal volume ventilation because this is lung protective. Okay, we're trying to not cause any further injury. So these are conditions commonly associated with digital clubbing. Uh, so just go over that while I drink water. You should drink water too if you have it. Okay. Intrathoracic neoplasm. Okay, so if you have intrathoracic neoplasm with digital clubbing, it's related to bronchiogenic carcinoma or metastatic cancer, malignant mesothelioma, or lymphoma. For all the conditions that are related to intrathoracic suppurative disease, these are lung abscess, empyema, bronchiectasis, cystic fibrosis, chronic cavitary infection, for example, fungal mycobacterial, lung diseases are idiopathic pulmonary fibrosis, asbestosis, pulmonary arteriovenous malformation, cardiovascular diseases are cyanotic congenital heart disease. Okay, so We have a patient with COPD. So, what is the most effective way to reduce mortality? Smoking cessation or continuous supplemental oxygen? Which one of these? Oh, yeah, I probably zoned out here and just went into forming jingles. Stop that smoke. Seize the cigs. Say no to tobacco. COPD is horrible. Don't let smoking be tolerable. Okay. Um. So yeah, smoking cessation is the most effective way to reduce mortality. Differential diagnosis based on DLCO. Okay, if there's low DLCO with obstructive pattern, that is FEV1, FVC is lower than 70%. And okay, so let's go this way. So if we have an obstructive pattern with a ratio lower than 70%, and you see that they have low DLCO, it's emphysema. If it's normal, chronic bronchitis or asthma. If it's increased DLCO, it is still asthma. If its restrictive pattern is more than 70% of predicted, or FVC is more than 80% of the predicted, uh, with low DLCO, it is interstitial lung disease, sarcoidosis, asbestosis, and heart failure. Normal DLCO is musculoskeletal deformity, normal muscular disease. Increased DLCO, morbid obesity. Okay. Okay. Normal spirometry, uh, low DLCO, anemia, pulmonary embolism, pulmonary hypertension. Okay. So if it's normal but they are low DLCO, it could be because of anemia, pulmonary embolism, or pulmonary hypertension. Normal DLCO and normal spirometry, then nothing's wrong. Increased DLCO is seen in pulmonary hemorrhage and polycythemia. Okay. Theophylline is a non-selective phosphodiesterase inhibitor that causes bronchodilation and is occasionally used in the management of obstructive lung disease. Toxicity typically results from reduced hepatic clearance of the drug. For example, co-administration of a cytochrome P450 inhibitor, theophylline, with patients experiencing CNS, for example, tremor or seizure symptoms, cardiovascular tachycardia, arrhythmia, hypertension, and gastrointestinal, for example, vomiting manifestation. I'm gonna redo that one because I got zoned out since it's the last one. Okay, so theophylline is a non-selective phosphodiesterase inhibitor. Uh, we don't care about that, so let's take that out. Theophylline causes bronchodilation. Okay, it is occasionally used in the management of obstructive lung disease. Okay, toxicity typically results from reduced hepatic clearance of the drug. For example, co-administration with cytochrome P450 inhibitor. Okay, got it. So you have buildup of theophylline if you're giving um, cytochrome P450, right, inhibitor. So with patients experiencing these symptoms like tremors, seizures, tachycardia, tachyarrhythmia, hypertension, and vomiting. Okay, got you. So we need to know what the cytochrome P450 inhibitors are. There is a mnemonic for it. I have it somewhere in my room. But right, so I found it where it was. So these are the inhibitors, cytochrome P450. Sodium valproate. It was on sickfaces.com when I'm really drinking grapefruit juice. Okay. So sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, acute alcohol overuse, chloramphenicol, erythromycin, clarithromycin, ciprofloxacin, uh, omeprazole, metronidazole, sulfonamide, um, amiodarone, ritonavir, and grape juice. So these are all the cytochrome P450 inhibitors. So thank you for being with me throughout this note reading for pulmonary. Good luck with your questions on internal medicine portion of all the recipe questions. See you until next time.